Welcome to this video entitled Gastroesophageal Reflux Disease. Let's begin with a definition. Gastroesophageal reflux disease, abbreviated as GERD, refers to symptoms or mucosal damage resulting from the abnormal retrograde movement of gastric contents from the stomach into the esophagus. When the esophagus is repeatedly exposed to refluxed material for prolonged periods, inflammation of the esophagus, also known as reflux esophagitis, can occur, and in some cases it progresses to erosion of the squamous epithelium, also known as erosive esophagitis. Severe reflux symptoms associated with normal endoscopic findings are referred to as symptomatic gastroesophageal reflux disease, non-erosive reflux disease, or endoscopy-negative reflux disease. Let's now focus on the pathophysiology of gastroesophageal reflux disease. 1. The key factor in the development of gastroesophageal reflux disease is the abnormal reflux of gastric contents from the stomach into the esophagus. 2. In some cases, gastroesophageal reflux is associated with defective lower esophageal sphincter, abbreviated as LES, pressure or function. Patients may have decreased lower esophageal sphincter pressures related to spontaneous transient lower esophageal sphincter relaxations, transient increases in intra-abdominal pressure, or an atonic lower esophageal sphincter. A variety of foods and medications may decrease lower esophageal sphincter pressure, as shown in Table 24.1. 3. Problems with other normal mucosal defense mechanisms may also contribute to the development of gastroesophageal reflux disease, including prolonged acid clearance time from the esophagus, delayed gastric emptying, and reduced mucosal resistance. 4. Aggressive factors that may promote esophageal damage upon reflux into the esophagus include gastric acid, pepsin, bile acids, and pancreatic enzymes. The composition and volume of the refluxate and the duration of exposure are the most important aggressive factors in determining the consequences of gastroesophageal reflux. We will now progress to the clinical presentation of gastroesophageal reflux disease. 1. The hallmark symptom of gastroesophageal reflux and esophagitis is heartburn, or pyrosis. It is classically described as a substernal sensation of warmth or burning that may radiate to the neck. It is waxing and waning in character and is often aggravated by activities that worsen gastroesophageal reflux, e.g., recumbent position, bending over, and eating a high-fat meal. Other symptoms include water brash, hypersalivation, belching, and regurgitation. 2. Atypical symptoms include non-allergic asthma, chronic cough, hoarseness, pharyngitis, dental erosions, and chest pain that mimics angina. 3. Inadequately treated gastroesophageal reflux disease may lead to complications from long-term acid exposure such as continual pain, dysphagia, and adenophagia. Other severe complications include esophageal strictures, hemorrhage, Barrett's esophagus, and esophageal adenocarcinoma. Pause the video and carefully scrutinize Table 24.1 summarizing foods and medications that may worsen gastroesophageal reflux disease symptoms before advancing to the next slide. Next we will discuss the diagnosis of gastroesophageal reflux disease. 1. The most useful tool in the diagnosis of gastroesophageal reflux is the clinical history, including both presenting symptoms and associated risk factors. Patients with mild, typical reflux symptoms do not usually require invasive evaluation. A clinical diagnosis of gastroesophageal reflux disease can be assumed in patients who respond to appropriate therapy. 2. Further diagnostic evaluation should be performed in those who do not respond to therapy, who present with alarm symptoms, e.g., dysphagia, weight loss, or who have long-standing gastroesophageal reflux disease symptoms. 3. Endoscopy is the preferred technique for assessing the mucosa for esophagitis and complications such as Barrett's esophagus. It enables visualization and biopsy of the esophageal mucosa, but the mucosa may appear relatively normal in mild cases of gastroesophageal reflux disease. 4. A camera-containing capsule swallowed by the patient is a new technology for visualizing the esophageal mucosa, PIL-CAM-ESO. The procedure is less invasive than endoscopy and takes about 20 minutes to perform in the clinician's office. Images of the esophagus are downloaded through sensors placed on the patient's chest that are connected to a data collector. The camera-containing capsule is passed in the stool. 5. Barium radiography is less expensive than endoscopy but lacks the sensitivity and specificity needed to accurately determine the presence of mucosal injury or to distinguish Barrett's esophagus from esophagitis. 6. 24-hour ambulatory pH monitoring is useful in patients who continue to have symptoms without evidence of esophageal damage, patients who are refractory to standard treatment, and patients who present with atypical symptoms, e.g., chest pain or pulmonary symptoms. The test helps to correlate symptoms with abnormal esophageal acid exposure, documents the percentage of time the intraesophageal pH is low, and determines the frequency and severity of reflux. 7. Omeprazole given empirically in standard or double doses as a therapeutic trial for diagnosing gastroesophageal reflux disease may be as beneficial as ambulatory pH monitoring while also being less expensive, more convenient, and more readily available. However, there is no standard dosing regimen. Standard dose or double dose omeprazole has been used. 8. Esophageal manometry to evaluate motility should be performed in any patient who is a candidate for anti-reflux surgery. It is useful in determining which surgical procedure is best for the patient. Next we will discuss the desired outcome. The goals of treatment are to reduce or eliminate symptoms, decrease the frequency and duration of gastroesophageal reflux, promote healing of the injured mucosa, and prevent the development of complications. Next we will discuss the treatment of gastroesophageal reflux disease. Let's begin with a general approach. 1. Therapeutic modalities are targeted at reversing the pathophysiologic abnormalities. These include decreasing the acidity of the refluxate, decreasing the gastric volume available to be refluxed, improving gastric emptying, increasing lower esophageal sphincter pressure, enhancing esophageal acid clearance, and protecting the esophageal mucosa, as shown in Figure 24.1. 2. Treatment is categorized into the following modalities. A Phase 1. Lifestyle changes and patient-directed therapy with antacids and/or non-prescription histamine 2 receptor antagonists, abbreviated as H2-RA, or proton pump inhibitors, abbreviated as PPIs. B. Phase 2. Pharmacologic interventions with standard or high-dose acid-suppressing agents. C. Phase 3. Interventional therapies, anti-reflux surgery or endoluminal therapies. 3. The initial therapeutic modality depends in part on the patient's condition, symptom frequency, degree of esophagitis, presence of complications. Historically, a step-up approach has been used, starting with Phase 1 and then progressing through Phases 2 and 3 if necessary, as shown in Table 24.2. A step-down approach is also effective, starting with a proton pump inhibitor once or twice daily instead of a histamine 2 receptor antagonist, and then stepping down to the lowest acid suppression needed to control symptoms. 3. Lifestyle modifications should be started initially and continued throughout the treatment course, as shown in Table 24.3. Pause the video and carefully scrutinize Figure 24.1 illustrating therapeutic interventions in the management of gastroesophageal reflux disease before advancing to the next slide. Next we will look at antacids and antacid alginic acid products. 1. Antacids provide immediate, symptomatic relief for mild gastroesophageal reflux disease and are often used concurrently with other acid-suppressing therapies. Patients who require frequent use for chronic symptoms should receive prescription-strength, acid-suppressing therapy instead. 2. An antacid with alginic acid, marketed as Gaviscon, is not a potent acid-neutralizing agent, but it does form a viscous solution that floats on the surface of the gastric contents. This serves as a protective barrier for the esophagus against reflux of gastric contents and reduces the frequency of reflux episodes. The combination product may be superior to antacids alone in relieving symptoms, but efficacy data indicating endoscopic healing are lacking. 3. Antacids have a short duration, which necessitates frequent administration throughout the day to provide continuous acid neutralization. Typical doses are 2 tablets or 1 tablespoonful 4 times daily, after meals and at bedtime. Nighttime acid suppression cannot be maintained with bedtime doses of antacids. Let's now discuss H2 receptor antagonists. See metadine, ranitidine, famotidine, and nizatidine. 1. The H2 receptor antagonists in divided doses are effective for treating mild to moderate gastroesophageal reflux disease. Low-dose non-prescription products may be beneficial for symptomatic relief of intermittent heartburn and for preventing meal-provoked heartburn in patients with mild disease. For non-erosive disease, H2 receptor antagonists are given in standard doses twice daily. For non-responding patients and those with erosive disease, higher doses and/or 4 times daily dosing provide better acid control. See Table 23.2. 2. The efficacy of H2 receptor antagonists in gastroesophageal reflux disease is highly variable. Although standard doses produce symptomatic improvement in about 60% of patients, endoscopic healing rates average only about 50%. The more severe the esophageal damage, the poorer the response. Higher doses and prolonged courses, that is 8 weeks or more, are frequently required. 3. The H2 receptor antagonists are generally well tolerated. The most common adverse effects are headache, somnolence, fatigue, dizziness, and either constipation or diarrhea. Cimetidine may inhibit the metabolism of theophylline, warfarin, phenytoin, nifedipine, and propanolol, among other drugs. 4. Because all of the H2 receptor antagonists are equally efficacious, selection of the specific agent should be based on differences in pharmacokinetics, safety profile, and cost. Pause the video and carefully scrutinize Table 24.2 summarizing a therapeutic approach to gastroesophageal reflux disease before advancing to the next slide. Pause the video and carefully scrutinize Table 24.2 summarizing a therapeutic approach to gastroesophageal reflux disease before advancing to the next slide. Pause the video and carefully scrutinize Table 24.3 summarizing non-pharmacologic treatment of gastroesophageal reflux disease with lifestyle modifications before advancing to the next slide. Next we will discuss proton pump inhibitors. Let's look at esomeprazole, lansoprazole, omeprazole, pantoprazole, and rabeprazole. 1. Proton pump inhibitors block gastric acid secretion by inhibiting hydrogen potassium adenosine triphosphatase in gastric parietal cells, which results in profound and long-lasting antisecretory effects. 2. Proton pump inhibitors are superior to H2 receptor antagonists in patients with moderate to severe gastroesophageal reflux disease, including those with erosive esophagitis, complicated symptoms, i.e. Barrett's esophagus, strictures, and non-erosive gastroesophageal reflux disease with moderate to severe symptoms. Relapse is common in these patients, and long-term maintenance therapy is generally indicated. Symptomatic relief is achieved in approximately 83% of patients, and endoscopic healing rates are about 78% at 8 weeks. 3. Proton pump inhibitors are also efficacious in patients refractory to H2 receptor antagonists and are more cost-effective than H2 receptor antagonists in patients with severe disease. 4. Proton pump inhibitors are usually well tolerated. Potential adverse effects include headache, dizziness, somnolence, diarrhea, constipation, nausea, and vitamin B12 deficiency. All proton pump inhibitors can decrease the absorption of drugs such as ketoconazole or itraconazole that require an acidic environment for absorption. Other drug interactions vary with each agent. 5. The proton pump inhibitors degrade in acidic environments and are therefore formulated in delayed-release capsules or tablets. Lansoprazole, esomeprazole, and omeprazole contain enteric-coated, pH-sensitive, granules in a capsule form. In patients unable to swallow the capsules, the contents can be mixed in apple sauce or placed in orange juice. In patients with nasogastric tubes, the contents should be mixed in 8.4% sodium bicarbonate solution. Esomeprazole granules can be dispersed in water. Lansoprazole is also available in packets for oral suspension and delayed-release orally disintegrating tablets. The packet for oral suspension should not be placed through nasogastric tubes. Patients taking pantoprazole or rabeprazole should be instructed not to crush, chew, or split the delayed-release tablets. 6. Zegeride is a combination product containing omeprazole 20 or 40 mg with sodium bicarbonate in immediate-release oral capsules and powder for oral suspension. It should be taken on an empty stomach at least 1 hour before a meal. Zegeride offers an alternative to the delayed-release capsules or the IV formulation in adult patients with nasogastric tubes. 7. Lansoprazole, esomeprazole, and pantoprazole are available in IV formulations for patients who cannot take oral medications, but they are not more efficacious than oral preparations and are significantly more expensive. 8. Patients should be instructed to take oral proton pump inhibitors in the morning 15 to 30 minutes before breakfast to maximize efficacy, because these agents inhibit only actively secreting proton pumps. If dosed twice daily, the second dose should be taken approximately 10 to 12 hours after the morning dose and prior to a meal or snack. 9. All of the proton pump inhibitors are safe and effective, and the choice of a particular agent is likely to be based on cost. And now we will look at promotility agents. 1. Promotility agents may be useful as adjuncts to acid suppression therapy in patients with a known motility defect, e.g., lower esophageal sphincter incompetence, decreased esophageal clearance, delayed gastric emptying. However, these agents are generally not as effective as acid suppression therapy and have undesirable side effects. 2. Cisaprade has comparable efficacy to H2 receptor antagonists in patients with mild esophagitis. It is no longer available for routine use because of life-threatening arrhythmias when combined with certain medications and other disease states. It is currently available only through a limited access program from the manufacturer. 3. Metoclopramide, a dopamine antagonist, increases lower esophageal sphincter pressure in a dose-related manner and accelerates gastric emptying. Unlike cisaprade, it does not improve esophageal clearance. Metoclopramide provides symptomatic improvement for some patients with gastroesophageal reflux disease, but substantial evidence of endoscopic healing is lacking. Tachyphylaxis and side effects limit its usefulness. Commonly reported adverse reactions include somnolence, nervousness, fatigue, dizziness, weakness, depression, diarrhea, and rash. 4. Bethanacol has very limited value and is not routinely recommended for the treatment of gastroesophageal reflux disease because of unwanted side effects. Next we will discuss mucosal protectants. 1. Sucralfate is a non-absorbable aluminum salt of sucrose octasulfate that has limited value and is not routinely recommended for treatment of gastroesophageal reflux disease. And now let's discuss combination therapy. Combination therapy with an acid-suppressing agent and a prokinetic agent or mucosal protectant seems logical, but data supporting such therapy are limited. This approach should be reserved for patients who have esophagitis plus concurrent motor dysfunction or for those who have failed high-dose proton pump inhibitor therapy. We will now look at maintenance therapy of gastroesophageal reflux disease. 1. Although healing and/or symptomatic improvement may be achieved via many different therapeutic modalities, 70% to 90% of patients relapse within 1 year of discontinuation of therapy. 2. Long-term maintenance therapy should be considered to prevent complications and worsening of esophageal function in patients who have symptomatic relapse after discontinuation of therapy or dosage reduction, including patients with complications such as Barrett's esophagus, strictures, or hemorrhage. 3. Most patients require standard doses to prevent relapses. H2 receptor antagonists may be an effective maintenance therapy in patients with mild disease. The proton pump inhibitors are the drugs of choice for maintenance treatment of moderate to severe esophagitis. Usual once-daily doses are omeprazole 20 mg, lansoprazole 30 mg, rabeprazole 20 mg, or esomeprazole 20 mg. Lower doses of a proton pump inhibitor or alternate day regimens may be effective in some patients with less severe disease. 4. On-demand, maintenance therapy, by which patients take their proton pump inhibitor only when they have symptoms, may be effective for patients with endoscopy-negative gastroesophageal reflux disease. Finally, we will discuss evaluation of therapeutic outcomes. 1. The short-term goals are to relieve symptoms such as heartburn and regurgitation, so that they do not impair the patient's quality of life. 2. The frequency and severity of symptoms should be monitored, and patients should be counseled on symptoms that suggest the presence of complications requiring immediate medical attention, such as dysphagia or adynophagia. Patients with persistent symptoms should be evaluated for the presence of strictures or other complications. 3. Patients should also be monitored for the presence of atypical symptoms such as cough, non-allergic asthma, or chest pain. These symptoms require further diagnostic evaluation. Thank you.